Hello, everyone, and welcome to today's broadcast. How do we effectively screen and manage opioid use in the community? Presented by Dr. Carissa Van Den Berk-Clark, an assistant professor in the Research Division Department of Family and Community Medicine at St. Louis University School of Medicine. I'm Dr. Susie Valdez of LabRoots, and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I want to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on that Ask a Question box located on the far left of your screen. Type the questions into the drop-down box that appear on the screen. Our speaker will respond to you via email. If you have any trouble seeing or hearing this presentation, just click on the Ask a Box question box and let us know you're having a problem. This presentation is educational and thus offers continuing education credits. Click on the Continuing Education Credit tab located on the top right corner of your presentation window and follow the process to obtain those credits. Please join me now in welcoming our presenter, Dr. Carissa Van Den Berk-Clark. I will now turn the presentation over to her.
Hi, everybody. Again, I'm Carissa Van Den Berk, and I'm over at St. Louis University's Department of Family and Community Medicine. I have nothing to disclose except I have a few grants from the NIH focused on cardiovascular disease and PTSD, as well as a grant from Berk-Clark focused on psychiatric transitions of care. Today we're going to talk about the chronic pain and the opioid epidemic. Then we're going to go into how this is translated into the community, specifically with a focus on primary care and emergency room physicians. After that, we'll talk about challenges to implementation and dissemination of best practices. So, opioid epidemic by numbers, 116 people die from opioid-related drug overdoses per day. 11 million people misuse prescription opioids in the U.S. And this year, per year, about 42,000 people have died from opioids. With opioid deaths, there is obviously an association with increased access. So as we see, starting in 1992, there's been significant increases in the number of prescriptions for opioids that were given out. Basically around 2010 to 2013, people became aware of that these opioid prescriptions were actually causing a significant amount of harm. So many physicians in many states started regulating more the use of these opioids, and fewer prescriptions went out. People there then also at the same time, heroin became more available, so people began switching over. So we see the increases of heroin use, and we also start seeing, as synthetic opioids started hitting the streets, a lot of the heroin use switching over to synthetic opioids. This is also explaining what is going on with the increase in opioid deaths that have been going on in the past few years. So you can also see this very well geographically. With parts of the country where there's a lot of prescriptions given out, there is also a lot of deaths. The difference here, though, is that opioid use was in some ways encouraged by the medical system. This all started with Dr. Mitchell Max, who basically was the president of the American Pain Society at the time. And he wrote an editorial, very famous editorial, in the Annals of Internal Medicine in 1990, basically stating that pain is the fifth vital sign and that patients don't talk about their pain with their healthcare providers. That's a real problem. And they have, when they get any kind of opioid medication, they have a very difficult time getting the provider to adjust their dose. If they don't get opioid medications, they have a very difficult time getting them. Basically, healthcare providers don't believe that pain and relief is their job, and at least according to Mitchell Mack during this time period. And there was no expectations that providers would be able to reduce pain. So basically, Dr. Max had given a bunch of recommendations to physicians to make pain more visible. He also thought it was really important to develop bedside tools for change to guide physicians and nurses to initiate and modify analgesic treatments. He thought that it was important to assure patients a place in the communications loop, increase clinician accountability by developing quality assurance guidelines, improving care systems, and assessing patient satisfaction. Another recommendation was to facilitate innovation and exchange of ideas. And then there was the most controversial one of work with narcotics control authorities to encourage therapeutic opioid use. The last one is one that is obviously going to haunt him. So in terms of quality improvement, one of the things that started happening to make physicians more responsible for pain, they began to basically recommend using measures like this brief pain inventory to measure pain on the part of patients. And basically they need to show changes in pain relief over time. So this sounds good. And then we enter the complexity of the medical world when the chronic pain patient shows up. So what is chronic pain? Chronic pain is essentially when somebody has any kind of pain that lasts longer than the recommended time of the injury. That, or it basically lasts more than 3 months for a non-back pain condition and more than 6 months for a back pain condition. So following this requirement of the 3 and 6 months, we have about 126 million people who considered to have chronic pain in the U.S. So it's almost around 55% of the U.S. adult population. About 6.3% have very severe pain. That means that they have pain every day, and they have a lot of pain every day. And essentially, the impact of chronic pain includes basically a large number of bodily complaints and essentially heightened proprio and enterocaptive awareness. Chronic pain is associated with multiple disease states, and it accounts for 5 of the top years lived without disability conditions globally. Much of the time, people with chronic pain also experience symptoms of cognitive and emotional distress. They have a lot of dysfunctional pain behaviors like physical inactivity. They sleep a lot. They also have a lot of relevant somatic and psychological comorbidities. One of the major ones is depression. So of these, who seeks care and who doesn't seek care? What we basically have seen with this is about 40 to 75% of chronic pain patients consult with a healthcare provider about their pain. And these people usually have more severe pain. What we see here is there's a higher pain severity, more interference with daily life. There's more spread of pain. There's lower quality of life. There tends to be lower income. Less likely to be employed. Also, who seeks care tend to be older, female, white, or mixed race, less educated, poor, Western states. Those who seek care tend to have worse health overall. They have more fatigue, higher depression, higher anxiety, more healthcare utilization, and more disability. So basically what's going on? Only individuals with chronic pain at the severe end are seeking care. These people have lots and lots of healthcare problems, not just the chronic pain, oftentimes lots of psychiatric problems, oftentimes lots of comorbid chronic health conditions, obesity, heart disease, hypertension. They also oftentimes, people with chronic pain oftentimes delay care or use other means in which to decrease their pain. So in 2014 alone, U.S. retailers dispensed 245 million prescriptions for opioid pain relievers. 63% of it was prescribed for less than 3 weeks, and 3 to 4% of adult population prescribed long-term opioid therapy. So, Shell et al. Uses a random sample of healthcare claims, and he found no demographic differences in risk of long-term opioid use, but someone who gets a script for more than 8 days is basically much more likely, and this is 13% of people who become long-term users. They're basically much more likely to become a long-term user of opioids. My mentor, Dr. Jeffrey Scher, basically looked at the number of VA and civilian electronic medical record registries and found that opioids were usually causing depression. So what's interesting about the sample is he basically did a washout period where there was no depression. And if you look at this top line, there's no depression prior to getting this chronic pain, this diagnosis of chronic pain, and basically they get a new diagnosis after opioid use. So what is the typical long-term user, opioid user? So, essentially a lot of times misusers are tracked within medical records by having these specific characteristics. And this does have an effect on how physicians decide to prescribe. So gender is not a predictor of misuse, but younger age is. White is predictor of misuse, but data is mixed because the samples are usually white. There's a history of substance abuse. There's a history of psychiatric disorders. There's a history of legal problems, and there's a history of traumatic stress. So how do patients feel about chronic pain patients? So early studies show that physicians showed little concern. This is a study by, there was a study by Turk et al. In 1994, and it showed that a sample of 6,000, around 7,000 US physicians, they showed little concern about tolerance, dependence, and addiction or state requirements. So then we look at, as we start kind of running into this opioid epidemic problem, and we look at later studies of 2010 and onwards, there is a significant concern about regulations and addiction on the part of physicians. So physicians start getting more worried, and so they start getting much more careful about prescribing when it comes to patients that have a background of substance use disorders and psychiatric disorders. But they also begin to have troubles with their chronic pain patients more generally. Physicians often describe their chronic pain patients as abusive or difficult. They often felt pressure to treat with opioids. They were not sure they believed patients' reports of pain. They were worried about secondary gain and diversion. Providers felt that treating these patients took a significant emotional toll on them, and they often felt frustrated, ungratified, and guilty. So what about patients? Patients describe suboptimal interactions with providers when seeking care for chronic pain. They, from the minute they walked into the door, they felt disrespected and distrusted. They felt like they were always suspected of drug seeking, and their symptoms were often dismissed as trivial and not warranting medical care. Patients also saw barriers to seeing providers promptly when having a pain episode and providers' access to pain documentation, and many patients felt like a burden both to the providers and office staff. So what does this mean for care? This means that patients feel like physicians ignore issues about chronic pain, while physicians think patients are always talking about pain. Patients feel constantly in a position of having to prove and document pain. Patients feel like they are treated as drug seekers. So what does this mean for care? We basically did a study of me and one of my mentors, Dr. Scher, who also did the depression and chronic pain study. We did a study looking at patient trust for a physician and physician trust of patients. And this was a study of chronic low back pain patients. And so essentially, when patients had a very high level of trust for physicians, there was really no differences in the way that physicians trusted them. But there were big differences when we started looking at whether patients used opioids or didn't use opioids, and patient beliefs about opioids. If patient believed that opioids worked best for them, they basically received a much lower level of trust from their physicians. If they believed, the patient themselves believed that they took too much medication, they also were much more likely to have not high physician trust on the part of their physicians. They doctor shopped. I mean, we didn't have that many people who reported that they doctor shop, but there's a trend here you can see. And we did see some differences in terms of age and whether they're applying for disability. So the physicians were also kind of making some kind of demographic assumptions on the part of patients, whether they trusted them or not trusted them. So what does this mean for care? Well, so we basically looked at, we did an odds ratio to see, you know, what was the likelihood of the physician having a high level of trust for their patients. And if the patient is using any kind of non-addictive treatment, the level of trust on the part of the physician rises really significantly. I mean, it's almost, you know, the odds almost go up 3 times. But, you know, we see that it is a steep reduction in trust once we get to believing, you know, patients who believe that opioids work best, or patients who take too much medication. Another thing that me and Dr. Shear and one of our pre-doctoral fellows worked on was videotaping, audio taping communications between physicians and chronic pain patients who are asking for pain medication. And we basically kind of did a more broad study with a focus on not just opioids, but any kind of pain medication. And, you know, there's one thing is that the one thing we already know is that the doctor visits within the primary care setting usually take place through a series of stages. There's this opening stage where people kind of chat and, you know, get comfortable, and the physician tries to just kind of do a little bit of small talk. Then the patient presents their complaint. The doctor examines the patient. The doctor gives a diagnosis. The doctor provides the treatment plan. And then there's the closing. And one thing we did see was there was quite a lot of, you know, going back to the need to prove your pain. There was a significant amount of that the patients were constantly during these interactions trying to prove their pain. Doctors took more time with opioid patients, and there was more effort put into establishing a relationship during the opening stage. So, you know, during the opening stage with a typical opioid patient, they would chat and ask much more questions about their personal life and how they were doing, and they would try to bring up antidotes. Doctors often needed to repeat stages because patients would communicate new aspects of chronic pain. So they'd be showing different MRIs and different other parts of their charts to bring up different types of aspects to prove that something was going on. And doctors were dealing with significant ambivalence about opioid use. But opioid users also felt the need to remind doctors that they are afraid of addiction. So I think these findings hint at the dynamic that plays out when doctors try to change treatments in any way a patient isn't comfortable with. So there's been like a recent systematic review by Frank et al., which looked at when physicians tried to either taper a patient or provide some sort of medication to reduce opioid use. And they found that between 21 and 100% of patients in higher quality studies discontinued opioid use with their PCPs. However, about 21.7% were using opioids again at follow-up. And, you know, there's a real mix of quality within these studies, but and there's also, you see that there's a range here too, with about 0 to 45% using opioids again. So why such a high rate of failure? Because intervention efficacy does not just depend on what is put into them. So, you know, we see here this flow chart. We have the input, we have older females, lower SES, higher perceived pain severities, low quality of life, high prevalence of mental health disorders. And then there's another input is the efficacies of these interventions. It could be through lab experiments, that can be pharmaceuticals that we have, these opioid analgesics, or NSAIDs, or other types of alternatives like physical therapy, and they're put into this black box, and after those inputs are processed through the black box, we have the outputs. And the outputs are, you know, the dependence, adequacy of pain management, long-term opioid use. The black box is this mystery. And that's what we need to figure out in order to make sure that we can reduce the long-term opioid use, misuse, the dependence, and the adequacy of pain management. And we have a problem translating these interventions through science into real world settings. So this is another flow chart by Powell et al. Without understanding enabling factors, insurance, access to care, organizational factors, and institutional factors, we have a very difficult time understanding why things work and don't work. So another way of thinking about physicians and to explain what occurs within primary care, emergency room offices, is to think of physicians as general gatekeepers to these types of physicians as general gatekeepers to the entire healthcare system. This system, of course, is enormously complex, and they basically have to figure out ways in which to make their job more manageable. So how do they make their job more manageable? The way that they make their job more manageable is by their use of discretion. And the word discretion is used in sociological literature, and it had been really heavily used to explain why people get certain benefits, and why some people get certain benefits and other people don't get those benefits from different social programs, most notably from welfare programs. But it basically can be translated over to many different fields where somebody works with the public and they have power to determine whether somebody gets something or they don't get something. In this case, you know, the physician has the power to determine whether somebody gets an opioid prescription versus somebody not getting one. So basically the research on discretion shows that what occurs is that people use their discretion to cope with their working conditions. And by what I mean, what working conditions is, what I mean by working conditions, I mean they're dealing with a complex system where there's never enough resources to basically make people healthy. There's a lot of demand. I mean, you could see this really clearly within health services, especially when it comes to primary care, where there's never enough primary care doctors. People have to wait a long time to go to see a primary care doctor. And then there's also the problem of ambiguous goal expectations. People expect these primary care doctors to make them healthy, but what does that mean? And how does one do that? Sometimes there's very clear treatments for health problems, but chronic pain, again, it's very unclear, it's very nebulous. Then there's the issue of patient leverage. I mean, essentially, healthcare patients are also consumers, and the physician does have to attract enough of them to keep a practice going. Even within large health systems, there's requirements to have certain numbers of patients. And so basically, within the field of medicine, physicians, just like any other kind of field, health services, physicians gain tools to develop discretionary routines. They learn these routines from other physicians, just like other, gatekeeping, civil service people learn these discretionary routines from other people working in the field. And basically, it's these routines that explain what happens in this black box. So essentially, about 10% of primary care visits involve opioid medications. So you can see there's a lot of discretionary opioid prescribing that goes on. Primary care providers provide the majority of care for chronic pain, and that tends to give more opioids to higher utilizers, patients with increased comorbidity, higher depression, nicotine dependence, patients who are older and white, have Medicare insurance, and where there is less state regulation constraints. This is a study that I've worked on with some of the people in my my lab that's focused on primary care as emergency room physicians. We got a hold of some data that basically included some of the things that went on during the visits. So physicians were able to record whether or not the patient requested opioids. Also, they were recording, like some of the patient behaviors, like they tended to prefer to have opioids, other types of medication. They used alternative treatments, etc. And then we also looked at pain severity and pain interference. And so patient behaviors seems to be an effective deterrent in terms of whether or not they get opioids. So when a patient seems to be having problems managing their opioid use, the physician is much more likely to refuse to give the opioids. But this seems to wash out once patients start requesting opioids. So it looks like, according to this model 2 and 3, that physicians basically they are really heavily influenced by patient requests for opioids. So when the patient gives pressure, they are much more likely to do it, and especially when the patient has a significant amount of pain severity. So they giving the pressure, there's evidence of pain severity. It really does influence whether or not the patient gets an opioid. So, one thing that we have is becoming more and more helpful is the prescription monitoring programs. This is a program that documents opioid prescribing in a centralized state database. Basically almost every state, but my home state of Missouri has one. They do have influence on clinician discretion because they can be theoretically incorporated easily into the workflow. They're legally mandated. But these PDMPs would sometimes reveal addiction safety concerns, which require physicians to have to make decisions whether to share the PDMP information with clients, openly discuss concerns, avoid discussions altogether, approach discussion confrontationally. So, so what would oftentimes happen is physicians sometimes don't look at these PDMPs in order to avoid these problems, because they don't want to have to get into all these very difficult discussions. They don't want to have to switch into this role that they don't know how to manage of being a substance abuse treatment counselor. And so a lot of times they avoid it if they can. So patients need individual reasons for tapering. So CDC guidelines, medical associations, state, federal regulations also pressure physicians to reduce opioid prescribing. However, to get the long-term opioid users to taper requires negotiation. They need individual reasons. They don't need a physician that just goes, there's a CDC recommendation and this is what you need to do. And the goal is to try to get patients to taper, to do it in a way that it includes the patient, but negotiating dosage isn't always possible. These are lengthy, difficult discussions. The patients need to be assured that they will not be abandoned, or that they won't necessarily be denied opioids in the future. So physicians play a big role in the provision of opioids, but there are also other important gatekeepers. One of those is pharmacists. They act as a medication expert on a healthcare team, but the opioid crisis makes them have to try to balance both health and criminal justice. They can refuse to dispense rather than proactively providing medication. So when they see something that seems that doesn't seem right with a script that they get, they can refuse to dispense it. They could basically make phone calls. They can call the police if they see any kind of safety issue. But one problem is that they're not trained how to do this in school. In physician school, they usually, there's an assumption that people are coming in with scripts that are the scripts that they're supposed to get, and that they are supposed to fill them correctly and to not give the person any serious problems with it, and just give them specific advice about how to manage that medication as they take it. So what happens is these PharmDs oftentimes don't want to argue with the physicians who initially, another issue is that they don't want to argue with physicians who initially provided the medication. Another thing that occurred is that, some of these pharmacists, they were afraid to basically call the police or cause problems with patients who came in with scripts that looked questionable. But if they were in a dangerous neighborhood, or they oftentimes didn't feel even safe leaving the facility, the pharmacy. So, another thing that pharmacists had been doing was the distribution of naloxone. One of the more well-known programs for the distribution of naloxone through pharmacists was the Stop OD New York City program. And they essentially basically included a specific protocol for pharmacies and a map to the nearest pharmacy offering Narcan, like a nasal spray to prevent overdose. So according to the New York Times investigation, 720 of basically 1,100 pharmacies listed as providing Narcan, only a third actually had it in stock and would dispense it without prescription. Workflow and protocols were not worked out within pharmacies, and frontline the pharmacists and the frontline workers who were there didn't know the rules. It was also very expensive, and so a lot of pharmacies didn't want to you know, a lot of individuals would come to the pharmacy to go get the medication, and it was too expensive to pay for it. There's similar issues found with CVS when it announced it would provide naloxone without a prescription. This is a map of all the different programs that give kits to laypersons for naloxone in the country, which is actually kind of interesting. It's from 1996 to 2014. So about 150,000 people had participated in the program. And essentially these kits were a lot of times given to laypersons that had like a family member who had a substance use disorder, or it was given to police, or it was given to emergency medical people, ambulance drivers, and EMS. It was given to EMS, and they were basically supposed to deliver this medication to these to people who are in opioid crisis. And you know, studies show that they can and will use these Narcan medications if they're properly trained, but respondents needed to stay with the overdosing person, so this starts getting complicated. The dose might be insufficient, especially when people are, you know, using different kinds of drugs together, polysubstance use, or they are using fentanyl. And, you know, most of these kits went to family members, and police officers often feared using these kits because of liability issues. So, you know, coming down, I have been aware that a lot of people who would be watching this this talk might be basically bench scientists, and they might be designing, you know, medications, or basically doing laboratory testing, or other types of things like that. That are related to substance use. And so I wanted to basically just bring home some of these things, to answer some of those questions before they happen. So, you know, laboratory testing is recommended to identify substance use. I mean, it's the most clear way of determining whether somebody is using, opioids is to basically take a urine test. But it needs to be done along with safe prescribing. So essentially it's recommended that, you know, when somebody gets prescribed opioids, they also get a urine test. It's basically more effective than any other physician tool for detection. Urine testing recommended for pain. Basically, the urine testing is recommended for pain management patients. So any pain patient that someone has, they should get a urine test. And testing is also provides understanding of all the drugs taken to ensure no negative drug interactions, and laboratory testing does not necessarily improve outcomes in pain management patients. So what does that mean? It means that primary care physicians who see most of the pain patients have already a difficult time building trusting positive relationships with pain patients. So if we try to bring in a urine test, which basically says, you can tell us what you're doing and what medications you're using, but we don't really trust you. We need to have something to really verify whether you're lying to us. It brings a lot more complexities into the room. So for that reason, a lot of physicians are hesitant to use something like a urine test. But this also kind of clarifies how like some of these simple measures of screening can cause their own issues within a primary care environment. You know, you also have to consider when you are creating any kind of new types of screening instruments or treatments, how they fit into a primary care environment. The frontline professionals, specifically physicians, have very little time and don't have resources. There's money within health systems, but there's less money within primary care, and there's serious problem with time. There's a lot that they need to accomplish within 15-minute time increments. Leverage needs to be considered because patients are voluntary. And frontline workers have specific roles, and they feel most comfortable when they can do those roles. They don't want to take the role of, like, a physician doesn't want to take the role of a policeman, you know. But a policeman would be perfect, doesn't want to take the role of the physician either. So this brings it to a close, and we bring it to the last slide where we say only the one that does not question is safe from making a mistake. So please feel comfortable asking questions as you need, and I look forward to hearing from you. These are the references.
Thank you, Dr. Van Berk-Clark, for that informative presentation. I want to remind our viewers that if they have any questions you'd like to ask, please do so now, and our speaker will follow up with your questions via email. I'd also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to remind everyone that today's webcast will be available for on-demand viewing through February 2019. You'll receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now, and thanks for joining us. We hope to see you again soon. Bye-bye.